Hello everyone. Our presentation is based on the Better Mental Health Care Americans Act, and more specifically, we will be analyzing the policy's effect on youth covered by Medicaid. My name is Leanne, and my fellow group members are Shukri, Kai, and Sophia. So some background on the policy and the efforts to better the mental health of young children in the U.S. include other policies that have been implemented over the past 2 decades, one of which being the Children's Health Act of 2000 and the Affordable Care Act of 2010. Some terms to have some background knowledge before moving forward with this presentation are mental health and mental disorder. The importance of this policy stems from the problems and consequences negative mental health inflicts on today's youth. Statistics from the CDC from 2018 to 2019 displayed that many adolescents have persistent feelings of sadness or hopelessness, have considered attempting suicide, and had major depressive episodes. There are currently not enough funds going towards addressing mental health to increase the access of treatments to better the mental health of children. In this figure, we can see the significance of being able to access mental health services, as over 50% of the reason why adolescents receive these services are due to feeling depressed. Some consequences include the increase of mental health issues among youth in the U.S. steadily increasing within the last 10 years, with the recent pandemic only adding to the problem. All in all, this has led to the declaration of a mental health crisis in 2022 with the U.S. Surgeon General.
Our policy solution is the Better Mental Health Care for Americans Act, which is Senate Bill 923, and it's a federal bill that was introduced in 2023, and it expands Medicaid coverage for screening, diagnosis, and treatment of mental health and substance use disorders. And Section 302, which we'll be highlighting, expands access to mental health care services for Medicaid-enrolled youth, which includes early detection and preventative mental health services for youth in educational, medical, and childcare settings, including telehealth, and reimbursements and incentives for childcare environments to provide mental health interventions, screenings, diagnostics, and coordination of care for at-risk children. And this policy overall intends to expand access to mental health services in order to combat the development of mental disorders, substance use, and rising suicide rates amongst youth. For Section 302, $100 million will be provided in grant funding to fund implementing physical and technological structures in states to provide mental health care services for Medicaid-enrolled children, and implementation of state programs to provide access to preventative early detection and treatment of mental health disorders in childcare, medical, and educational settings, and also creating a workforce in order to supply trainings, support, and technical aid that is required to provide the mental health care for children, and state reviews of how reimbursement through Medicaid in order to increase mental health care services will actually improve access to services to Medicaid-enrolled youth. For the policy landscape, we'll be highlighting 3 policies, and our first policy is the Mental Health Services for Students Act of 2020, which is House Resolution 1109, and it passed the House in 2020. And it's a federal bill that would provide funding towards partnerships with mental health care providers, training school staff to identify suicide and mental disorder risk, and behavioral support for students. And this bill has received significant support from the American Association of Child and Adolescent Psychiatry, in which they believe that this act helps to improve access to mental health care services for students and serves as a preventative measure for mental disorders. Our second policy is the Youth Mental Health and Suicide Prevention Act, which is Senate Bill 3628, and it was introduced in 2022, and it's a federal legislation that allocates grant funding in order to support educational campaigns, teacher trainings, and mental health support programs in order to prevent, screen, and treat mental health issues amongst children in schools. And there is significant support from educators and mental health professionals for this law, with individuals stating that this bill would help to reduce increasing rates of suicide and disorders amongst youth by providing mental health services in order to address signs early on. And our third policy is Consent to Mental Health Services, Assembly Bill 665, and it was introduced in 2023, and it's a California state bill that would allow youth that are 12 and older to be able to receive mental health services and treatment in outpatient settings. And this law has been faced with significant pushback, as opponents were claiming that this law would allow mental health care providers to take children out of parental custody to receive mental health services.
For a logic model, the first input would be staff, which would include mental health professionals, primary care physicians and pediatricians, educators, social workers, and foster care and child welfare workers. The second input would be a sustainable internet connection and providing tablets to eligible Medicaid enrolled youth. Note that eligible is defined as Medicaid enrolled households who do not have a source to receive virtual healthcare services such as a tablet, smartphone, laptop, or a desktop computer. The first activity for staff would be to develop evidence-based, person-centered, and culturally, linguistically, and developmentally appropriate resources geared toward prevention, identification, and treatment of psychosocial disorders such as depression and anxiety, and substance abuse disorders. The second activity for the second input would be to install fiber optics to regions with poor internet quality and mail tablets to eligible Medicaid enrolled families. First output would be a formalized report of the program plan outlining the presentation of educational materials to youth and legal guardians in the form of either a slide deck, flyer, poster, or pamphlet. And the second output would be that fiber optics would be installed and tablets mailed with a record of the shipping label. For short-term outcomes, the first would be increased knowledge of how to prevent, identify, and treat psychosocial and substance abuse disorders. And the second short-term outcome would be increased knowledge of the option to utilize telehealth and virtual health services. For intermediate outcomes, the first would be staff's ability to teach youth and their legal guardians about prevention and treatment, and the ability to better identify children with psychosocial and substance abuse disorders. The second would be an increase in the utilization of telehealth and virtual health services by Medicaid enrolled youth. And the first long-term impact would be decreased rates of children with psychosocial disorders and substance abuse disorder. And the second long-term impact would be an increased efficacy in diagnosing and treating Medicaid enrolled youth through telehealth and virtual health services. Our evaluation question for short-term impacts is, did S923 increase awareness of methods to prevent, diagnose, and treat mental health and substance abuse disorders? For intermediate outcomes, did S923 increase the use of telehealth and virtual mental health and substance abuse services by Medicaid enrolled youth? And for long-term impacts, did S923 decrease the prevalence of psychosocial and substance abuse disorders in Medicaid enrolled youth populations? For our evaluation design, we chose to investigate the long-term impacts. We chose a quasi-experimental design as a time series because there is not an international equivalent to use as a comparison group for Medicaid, which is a U.S. federal agency. There's also archival data for mental health outcomes of Medicaid enrolled youth and annual databases for youth mental health and substance abuse, which will be useful for future observations. The data will be collected annually for 8 years and organized by before and after policy implementation. Since the policy has been introduced in 2023, it would not be enacted until 2024. So the observations would begin being collected from 2020 to 2023, and it's also important to note that this was during the COVID-19 pandemic era when there was a significant increase in negative mental health outcomes such as increased anxiety and major depressive events, as well as substance use, leading to increased overdose among youth. And the data collection will continue from post-pandemic era 2024 to 2027. The archival data is available from the Center for Medicare and Medicaid Services from their report, Medicaid and CHIP Access, Coverage, and Behavioral Health Data Spotlight. And additional archival data and future data is available from the Mental Health of America Annual Youth Data Report.
Some challenges in evaluating this policy are due to the fact that Medicaid is the only insurance agency affected by this policy, resulting in the inability to compare it to another insurance group to see the efficacy of its implementation. Additionally, there is a lack of data specifically targeting mental health and substance use disorders of Medicaid-enrolled youth. And last but not least, there is no way to distinguish whether the results of the mental health and substance usage of Medicaid service youths was due to the implementation of the policy or other external factors.
There are a few implications for health equity that come with this act. First, S923 has the potential to improve health equity in populations directly through its plan to increase Medicaid coverage for youth mental health services. With this increased coverage, users under Medicaid will have access to these services without encountering the previous barriers of costs and accessibility that may have existed for many parents and families in the past. However, there's then a possibility for S923 to negatively impact health equity, as the requirement for Medicaid to cover additional services could ultimately lead to them increasing their prices, which would create economic disparity for those who might struggle to afford those increased premiums. These changes could neutralize any benefits for those in lower socioeconomic classes or brackets, and could fully be detrimental to them, as those who might not be able to handle these prices would fully lose out on these improved mental health services offered under the insurance plans. Finally, there is also potential for S923 to improve future health equity through its call for increased awareness and focus towards youth mental health issues. With a heavier emphasis on these issues than before, S923 could potentially bring mental health issues further into the forefront of health issues to address. This could result in better developments in diagnosis and treatments that could further improve services as a whole when it comes to addressing youth mental health issues. Finally, our thought-provoking question towards the class would be, what do you think has had the biggest contribution regarding the disparity of the focus on addressing mental health on a political level?